to record so we can share with folks who aren't able to attend, but want to welcome everybody to the February System of Care Learning Collaborative. I see new names joining us today, so that is great. If this is your first Learning Collaborative, I want to give you a special welcome. These are really intended to be for anybody, everybody in Oregon who's working in the system of care, participating on any of the regional groups, state groups, youth and family members. We're all here to learn from one another and with each other. So really, thank you for tuning in today. We are also joined today by two colleagues from Oregon Health Authority who are going to share a little bit about the EPSDT benefit, early prevention, screening, diagnosis, and treatment. I think I got that right. This is a new Medicaid benefit that got turned on last year, so it's been around for about a year. So I think really looking forward to learning about that benefit. If it's new to you, kind of getting an update on how it's going, and learning some tips and tricks about what to do when it's not working out in your region. So hope you brought lots of questions, and just excited to be in the space with you all today. I'm going to turn it over to Jessica and Liz, two wonderful folks from OHA who are going to be with us.
Hello.
Hi. Oh, before we get started, sorry. If everyone can introduce yourselves in the chat, your name, pronouns, kind of what region you are, or kind of what part of the state you are joining from today. And if there's specific things about EPSDT that you would like to make sure we hear about and talk about today, that would be great too. Put that in the chat. Okay, floor is yours, Jessica.
Thank you.
And I just want to check real quick. Are folks seeing just like a single slide, or are you seeing the version with notes? Yeah.
We got the right slide.
Okay.
Just a slide.
Cool. It's giving me like a multi-view thing that I haven't had before. So just
Yeah.
check.
It's good to see you, Liz. Hi.
I'm Jessica Ickes. I am the EPSDT lead with Medicaid. And my only information on the Super Bowl is actually a former student of mine played in it. But I didn't even watch the Super Bowl because my team wasn't playing. So can't help with that one. And I'm going to let Liz introduce herself.
Hi, everyone. I'm Liz Stewart, IHD, her pronouns. I am the Children's Health Policy Project Manager in OHA's Office of Health Policy. And so I'm the project manager for EPSDT and counterpart to Jessica. And I don't follow any kind of sportsing, and I wouldn't know an Usher song if it like showed up right in my face. So sorry. But, all right.
So for today, we will learn what changed at OHP and for whom gets EPSDT, what has and hasn't changed regarding coverage for children and youth, how to advocate for members who are denied services, and where to access additional information and submit questions.
All
right.
Did you want me to take the first bit, Jessica? All right. Jessica and I tag team these, and we sometimes switch off of who does what section here. So I'm going to give you the overview on EPSDT policy. So what it is and what it is that has changed relatively recently. So EPSDT is the Early and Periodic Screening, Diagnostic, and Treatment Program. Not a great acronym, but it's the one we're stuck with. Thanks for bearing with that. So EPSDT is a federally required benefit that provides coverage of complete health services for children and youth under age 21 enrolled in Medicaid, which in Oregon is the Oregon plan. So EPSDT requires coverage of all medically necessary and medically appropriate services, and that is based on the member's individual needs and their own history. Those determinations of medically necessary and medically appropriate have to be made on a case-by-case basis. So in Oregon, EPSDT really is the child and youth benefit within the Oregon Health Plan. So members under 21 do not have to enroll in a separate program to get EPSDT. If they are enrolled in OHP and are under the age of 21, they will have this coverage. And that is our webpage link at the bottom. And Jessica, maybe you can stick that in the chat as well. So we kind of said this, but wanted to reiterate. To qualify for EPSDT services, you just have to be an Oregon Health Plan member under the age of 21. And on their 21st birthday, OHP members would transition into the adult benefit. And the EPSDT requirements apply across both open card or fee-for-service OHP and CCO enrolled members. So the requirement, there's no differentiation between CCO and open card. And we got some shiny new data, so I put some numbers in here, but this requirement for EPSDT coverage covers more than a third of OHP members. So from our January data, there's over 500,000 OHP members under the age of 21. That's 37% of all OHP members that this coverage applies to. So to clarify, so most services under EPSDT and most services for children and youth have been provided in Oregon for many years. But until 2023, there were still some treatments that could still be denied for members under 21. And that was due to an agreement that Oregon had with the federal government based on the prioritized list of health services. And so if you're not familiar with the prioritized list, that is a tool that the Oregon Health Plan uses to determine coverage for many services. And there is what is called a funding line on that list. Historically and under the adult benefit, the services that are below that line could generally be sort of categorically denied. And that did apply for members under 21. That is no longer the case. That is why we have this good news star explosion on this screen. So as of January 1st of 2023, all medically necessary and appropriate services have to be covered for OHP members under 21, regardless of the prioritized list. That line on the prioritized list and determinations based on placement on the prioritized list are not, or denials based on things being below the line is not acceptable for EPSDT. Those determinations have to be made based on whether the service is medically necessary and medically appropriate for that individual based on their clinical history. And I am not seeing questions if they're coming up, so we will pause between sections. So just want to flag that, folks. So just to go a little bit more in detail, again, EPSDT basically requires that anything medically necessary, medically appropriate be covered for this population. There is a large emphasis on prevention and screening and diagnosis. Of course, it's all in the EPSDT name and acronym. But ultimately what EPSDT requires coverage of is all services needed to find or treat illness or injury, other changes in health. Definitely and has always included coverage of well child visits and adolescent well visits. Those are sometimes called well child checks, but these are standard screening and check-in exams. And so you can see the components of those on the screen. In Oregon, EPSDT follows the Bright Futures periodicity schedule, which is from the American Academy of Pediatrics, and it's the recommendation for the frequency with which things like well child visits and immunizations and all of those different kinds of screenings happen. Also included, of course, are screenings for vision, hearing, oral health. And then we want to be really clear that these two slides are not like an exhaustive list of what is ultimately, if it's determined to be medically appropriate and necessary for that individual, it should be covered. But trying to be clear that this is a comprehensive benefit. Covers behavioral health, prescription, all different kinds of therapies, vision, dental, medical equipment, durable medical equipment, school-based health services, personal care services, group of services. We're really trying to be extremely comprehensive here. Also, just to be clear, that does not mean that all services are covered in all cases. So CCOs and OHA can require a prior authorization for some services. So it is very important to remember that under EPSDT, there cannot be a prior authorization required for screening services. Services do have to be eligible for Medicaid coverage. There are some things that are not. And services have to have an appropriate a diagnosis and billing code, and those are fairly standardized. CCOs and OHA are allowed to use a preferred provider network. However, we are also required to make sure that we can connect members with providers if there isn't one. Like, for example, if a CCO doesn't have that specific kind of provider in their network, there is an obligation to make sure that the member can be connected to an appropriate provider and be covered. And also, Medicaid does have to be a good steward of public resources. And so CCOs and OHA can choose to cover whatever the least costly effective option is for the member. So we'll go into some examples later, but one example of that could be if a generic version of the medication is effective at meeting the member's needs, that's what would be covered versus the brand name that costs a lot more. Let's see what else. So just in terms of kind of a little bit of where we're at, both OHA and CCOs have to have been complying with this policy change and these coverage requirements since January 1st of 2023, and ensuring that services to OHP members under age 21 are not denied without an individual review for medical necessity and medical appropriateness. So again, those denial reasons should really be based on this thing, based on all of the clinical documentation and everything we're looking at is not medically necessary or medically appropriate for this use. It shouldn't be, it's below the prioritized list. That's no longer an acceptable denial reason. The definitions of medical necessity and medical appropriateness that apply to EPSDT are in Oregon Administrative Rule. Jessica's going to talk a little bit more about that in a bit. And again, we all have to follow the right features periodicity schedule. There are like process things that CCOs and OHA can differ in. So the actual prior authorization procedures, those might be different depending on which CCO you're working with. But the policy around how those things are done is consistent, and the same with billing as well. All right. So we're going to pause there. Are there any questions in the chat or otherwise before we move on?
No questions in the chat. I invite folks to raise their hand or.
I have a question. So I know that the prioritized list, I understand the idea that this isn't based on above or below the line and the diagnosis, it's based on medical appropriateness. But there's also on the prioritized list, there's certain services, CPT codes that pair or don't pair with diagnosis. So is that just all like gone for kids? You don't worry about those pairings anymore?
That's a really great question. So what I would say, and I'll ask Jessica to jump in too, is that, and I'm really glad you asked that, because we do want to reiterate that the prioritized list itself is a really important tool, and it's managed by the Health Evidence Review Commission and has a lot of research and evidence base behind it in terms of guidance for coverage of certain things and the way that some diagnoses and procedures are paired. So what we kind of say from the EPSDT perspective is the prioritized list should absolutely be used as a tool to help make a case or look at guidance for coverage. But when it comes to what is an actual denial reason, the placement on the list cannot be the denial reason. And so there are things that pair the way a diagnosis code and a procedure code sometimes pair, like the one code is above the line, one is below the line. Historically, that could be categorically denied. That is no longer acceptable. And EPSDT offers the space for a provider to make the case that, hey, I know that thing paired below the line, but I'm saying this is medically necessary or medically appropriate, or I think it should be this treatment that goes with this diagnosis. And here's why, clinical documentation for that determination to be made. Does that help answer your question? And then I can ask it, see if Jessica.
No, that did. That answered my question. Thank you very much. But and so a follow-up question to that, which is, I think it's, I know the answer to this, but so a service provider still has to submit the appropriate claim and the diagnosis that it's associated with. So they still have to come up with some kind of a CPT code to describe the service that they're asking us to fund.
Yes.
The billing process has not changed. It's the approval process that has changed.
Okay, thank you.
Yep, that's a really good clarification. All right, Jessica's gonna jump into this next.
Sure. There's a question in the chat, and I'm going to wait to answer that one because we will get there. But so going on to medical necessity and medical appropriateness. Next slide, please. So what do these terms mean? It is a requirement from the Centers for Medicaid and Medicare Services that we have. Can you go back a slide? Or had you skipped ahead?
I had skipped ahead.
Okay. Sorry. And so every state, including Oregon, has a definition for medical necessity. Most states include medically appropriate into their definitions of medical necessity. Oregon has them separate. That was determined long before EPSDT, and so it's going to remain that way. We are also the only state to have a definition for dentally appropriate. So that is why we have 3 definitions that we work with. But those definitions are in OAR, but and were updated this last year. They went into effect January 1, 2024. But medical necessity means a treatment that is required to prevent, diagnose, or treat a condition or to support growth, development, and participation in school or work. Medically appropriate means that the treatment is safe and effective. So in Oregon, we must have a treatment must be medically necessary and medically appropriate for that individual. Next slide, please. So CCOs and OHA are required to provide comprehensive EPSDT medically appropriate and medically necessary services needed to treat and ameliorate health conditions for members under age 21. And the term ameliorate is really what differentiates the EPSDT definitions and program from the adult program. We do not have to completely treat a something. We have to make better. We have to make more tolerable something for that individual under the age of 21. We know that not everything is curable, but we are able to make things better. So something very important to differentiate the two. This includes services which, based on the child's individual circumstances, improve the child's ability to grow, develop, or participate in school. Information must be sent that demonstrates medical necessity and appropriateness to OHA or the CCO to get something covered. And the better the information we get from those providers, the easier it is for us to approve those. Making sure that coding is done correctly, making sure that we receive the letters of medical necessity that explain why this individual needs this treatment or service or piece of equipment to help them. We don't know these individuals, but we are looking at their cases. So the more information and the better information we have, the easier it is for us. Next slide. So some examples about what is medically necessary but not medically appropriate. Liz brought up this, a drug that is used to treat a condition but is not safe for that particular individual because it would have an adverse interaction with another drug they are taking. Or an expensive medication is prescribed when a generic is available. Medically appropriate, but not medically necessary. This one we get asked a lot. Acne medication for a youth with acne, but the acne is not impeding their functioning or participation in school or other activities. So if it was impeding their functioning or participation in school or other activities, then we would definitely review that. Also, a child with a broken front tooth who could have a cap, but is not in pain or experiencing any impaired function. Next slide, please. On the behavioral health side, something is intensive in-home behavioral health treatment. So prior to EPSDT, 2 mental health diagnoses above the line were required at intake. So if an example, anxiety and PTSD, mixing up my acronyms here. And after EPSDT, may meet medical necessity and medical appropriateness if they have anxiety and a Z code. So an example is anxiety and problems related to negative life events in childhood. Z code 61.1, removal from home in childhood. Next slide. Residential services. So prior to EPSDT policy change, ADHD diagnosis was only approved for outpatient services. Post EPSDT, ADHD may be approved for residential if determined to be medically necessary and medically appropriate. Next slide. All right. Are there any questions? Okay.
There was one question in response to the eyeglasses.
Mm-hmm.
Would this circumvent current practices? So for example, a kid breaks their glasses 2 months after getting them, and now they need new glasses. Would they be able to get them replaced?
They should have been able to get them repaired or replaced previously, but the answer is yes. If it is medically necessary and medically appropriate for that individual, yes, they would be able to get them replaced. Okay. Any other questions? Somebody just came
Hi.
up.
Yeah, this is Jennifer Ferguson. I'm from Care Oregon. This may be too in the weeds for here, so happy to, take it offline if other questions. But it's sort of a logistical question I have. I work in our care coordination department, and we work with our RAP coordinators and intensive care coordinators about helping connect members with services and resources. And often there's this kind of logistical bridge or gap between care coordinators helping to find those resources, but then those resources or providers having to be the direct requester of services. And we don't always know how to encourage providers who might provide the service to request without there being kind of a relationship ahead of time, either through a contracted provider relationship or just sort of a known connection. So it's really just how do we navigate if these requests for authorization are to be submitted by the rendering provider or resource, how do care coordinators then go about finding those resources if we don't already know of them, and then connecting those resources to the authorization process? And this doesn't need to be answered here, but that is my question.
Okay.
So
Can I ask a favor and have you email us that question and we
Yes.
will respond to you? So the first email address I put in had a typo, so please use the second email address that I put in, epsdt.info. And we will follow up with you.
Great.
And
Thanks.
Jessica,
Yeah.
also call out, I think Jennifer put this question in the chat.
Oh,
yeah,
okay.
at least some version of it. Yes. Yes.
Yeah, we'd be happy to answer that, but we'll answer that one offline with more time. So moving on to member rights and what if a requested service is denied. So for OHP members under the age of 21, a service can be denied when the service is not medically necessary and medically appropriate for that individual. I can explain a case example that we just had recently. An individual outgrew their sit stander, happy to get them another one. However, the provider requested the wrong size. So we ended up needing to deny that. However, could make a phone call to that provider and say, what was your intent? Did you really mean for this to be the wrong size? You know, sometimes there are things like that. And they said, no, we just put in the wrong size. So wrong size, let us resubmit. No problem. They resubmitted, we approved. We all went on our happy way. So this does happen. So obviously it was medically necessary, but it was not medically appropriate because it was not the correct size for that individual. So any denial of OHP coverage must be in writing. Providers should not refuse to provide care or make necessary referrals. This is very important, that a denial needs to be in writing. This is not only our requirement, but it is also a requirement from CMS. And one of the reasons is that with that denial are the members and individuals' rights listed on there as to how to appeal or request review. So providers should always make the case to the CCO or OHA for coverage of a medically necessary, medically appropriate service for a member under 21. And we are working very hard on provider education about EPSDT coverage, but some providers may not have heard about the changes in coverage and may make assumptions about coverage. So the more people who know about EPSDT, the changes, the better off we all are. So again, members must be provided a written denial notice when denying a service. This may come from the CCO or from OHA. It must contain a statement of the intended action and effective date, the specific reasons and legal support for the action, an explanation of the individual's appeal and or hearing rights, and the member's rights to representation. So what is the recourse that our members have and providers? If a member, guardian, or provider disagrees with the denial decision, they can appeal it. Any denial notice should include instructions on how to appeal or request a hearing. And all OHP members have the right to a fair hearing for denials. Ensuring member access to services, we've included some contact information here, the OHP Client Services Unit. Members of a CCO should call the customer service line for the CCO. The number is on the back of the Oregon Health Plan card. The OHA Ombuds program, and their information is included here as well. We work very closely with our Ombuds program, so a great resource. Next slide.
And that is the end of this
That
set
one.
of slides. We have some
Great.
further resources, but want to make sure we pause here. Questions?
And also, if you have questions, don't hesitate to email us. That email address goes to everybody on the team. So if one of us is out, somebody can answer it as quickly as possible. Right now, the team is just Liz and I, so there are only 2 of us. So sometimes answers may take a little bit if they require research, but we will get back to you for sure.
Jessica and Liz, there's a question in the chat from Jesse. And Jesse, I wondered, do you feel comfortable coming off mute? And
oh yeah, sure. Thanks.
Okay. Yeah.
Hi. Yeah. So I just had a question pop in my own mind. And sometimes I wonder if my questions are somewhat in relation to the area that we serve, which is pretty rural. And so I was thinking about medical necessity and appropriateness, and sometimes when that comes up as a snafu. So like the example that came to mind is we get, I would say, fairly frequent requests regarding members who have autism spectrum disorder, who might require specialized like dental care, for example, to find a provider that can, you know, be supportive around sensory needs, perhaps be prepared with appropriate anesthesia, et cetera. And we'll have dental deny because they'll go, why are you sending this? This member has local dental. Where you have like MH or PCP provider being like, because of the diagnosis need, and there becomes kind of a who might trump medical appropriateness conversation for a service like that. So was just kind of curious to hear your thoughts on, you know, if some of this updates could be something that we can utilize as care coordinators to refer to in terms of like, can we take another look at this? It is appropriate given the need that's not dental in nature, but dental in nature, if that makes sense.
And yes, those are covered under EPSDT. It's a very simple yes. Understand that the application of that, it may not be so simple, but that would fall under, may not necessarily be medically necessary, but it is definitely medically appropriate for that individual in order to get the medically necessary treatment. So,
thank you.
yeah, I'm not sure. I hope that answers your question. If you need anything else, I would definitely recommend going to our webpage and looking at the provider guidance that we have posted there, as well as the CCO guidance documents that are posted there.
I was going to add that too. Yeah, there are some more documents on our webpage, and I can go through those in a minute as well. But I think that, you know, it is ultimately the say of the CCO or OHA to make that call based on documentation about medical necessity or medical appropriateness. But if you ever end up in a situation where things are feeling like inappropriate decisions are being made, we want you to escalate those either by contacting us or go through client services or our buds program. We definitely recommend going through an appeal or hearing, like those processes first, but want to make sure that things would be getting escalated if it's feeling like you keep hitting a dead end.
Thank you. I appreciate it.
Yeah.
Are there other questions? I know there was a question earlier in the chat, and I can't get back to it without the slide going all wonky because I click on my screen to get the chat and does that. But I think it was specifically about this of what recourse do families have, and I want to make sure that we answered that one fully.
yeah, I think that was from Hillary. Hillary, did you have anything else you want to ask about disputes?
Okay.
Oh, looks like Hillary jumped off.
Oh, okay.
But I'm assuming yes.
Okay, we will move on.
Sorry,
Oh,
faded out for a
There
second
you are. You were hiding.
Yeah, I was failing the test of running Zoom for today. Yeah, I think mine is covered, so thank you very much. I think it's the bits around the edges that I'm hearing. I think I sent you one that had come in from a parent around dyslexia, and is dyslexia treatment covered now under EPSDT? Because I know that's a hot button issue in the autism community. So it's some of these ones that have been historically hot button that now come up for conversation, I think, that is going to be interesting.
Yes, and regarding dyslexia, it is covered under EPSDT. So we did respond to that individual's question.
Thank you. Yeah, I saw that.
And it is tricky because yes, under EPSDT, if it's medically necessary and medically appropriate and can be demonstrated to be those things, it should be covered. And that's been that, as you said, it's those blurry edges where sometimes
Right.
it can
Yes.
get, yeah.
And I think an interesting one for a number of folks on this call, particularly around some of those things like dyslexia and some of the autism treatments that we sometimes see talked about in things like the IEPs. And there was a bullet on one of the slides around coverage for things that are for education, and it went too fast for me. Would you mind just refreshing me on that one? Because I think that may be of interest to a number of people here today.
So EPSDT does cover school-based health services, but again, the same thing applies. If it's medically necessary and medically appropriate for that individual in the schools, we will cover it. CMS issued a very extensive guidance document this past year in 2023 regarding EPSDT and school-based health services, and it expanded Medicaid coverage for school-based health services. So not just for students needing IEP or needing or special needs students, but also expanding coverage to students who might have Medicaid, but are needing behavioral health or go through a vision exam at the school or something like that, that Medicaid would cover those as well. So more to come on that one for sure. There is a lot there. And we are working very closely with our partners at ODE and how to implement those in Oregon.
So I can see a huge raft of things around ADHD that might well be deemed medically necessary around supports or different therapies that I've seen used. That are they things that are already being explored now by your team?
Yes, some of them are, and some of them are still being worked through because of billing issues or infrastructure issues in order to make those processes happen more smoothly for the school districts. So we are still working through the impacts of all of that.
Thank you.
Mm-hmm. Are there any other questions we haven't gotten to at this point? Well, maybe while Christy's looking through, I will point out these, the requirements we went through around denial notices and having denials in writing, those apply across OHP regardless. And so that's also a good thing for folks to know. This is not just for members under 21, but specific to members under 21 is that denial reasons cannot be based on location on the prioritized list. It has to be based on medical necessity and medical appropriateness. And so just want to bring that to folks' attention. And I think just a second call out to what Jessica said earlier, which is that like denials of coverage have to be in writing. A provider should no longer be saying, oh, OHP won't cover that. Like that's a big, we're changing 30 years of history of the prioritized list in Oregon. And so we know that's going to still be a long road for a lot of providers to wrap their heads around and get used to. But, you know, it used to be you glance at the prioritized list and, oh, it's below the line. We're not even going to try for it, or we're not going to go for it. And that is absolutely not acceptable under EPSDT. And so if you ever run into a case of someone getting that kind of a response of, you know, just a verbal denial, like we want to make sure that we are helping folks to and helping providers understand. And as we said, we've been trying to do lots of provider education, but you know, providers should always be submitting and making a case to OHA or the CCO for why that should be covered. If, you know, and we would want to have help families and members and the folks that are helping those members also know that they can ask for those denials in writing if they're not getting that. We know that shouldn't be on the member, but we also want folks to know that was their right. And that written denial comes from OHA or CCO, not from the provider. So those are things we want to know about if they're happening. All right. So going into some resources, this slide is not an exhaustive list of what is out there, but at our webpage, which is linked here, oregon.gov/EPSDT, that is where any and all things EPSDT Oregon live. And so all of the resources that we have produced thus far are there. All of the CCOs should also have web content around EPSDT for their members as well. But this is where the centralized across Oregon resources are. We do have an EPSDT fact sheet for members that's currently available in 13 languages. I will flag that we have some more member and family materials coming very soon that we're really excited about, that focus a bit more closely on this expansion and what it means to have things be medically necessary, medically appropriate. We're working on getting those into translation now, so we'll have some additional materials soon. We do have an FAQ that we found that's probably where we would refer partners, advocates, care coordinators, others to as sort of a first stop, is our FAQ that's available in English and Spanish, and we could provide additional languages upon request. There's also, as Jessica referenced, there's a guidance document for CCOs that outlines all the requirements that CCOs and OHA are held to under EPSDT. There's a guidance document specifically for providers. It's aimed a bit more at open card providers, but definitely a great resource and a lot of really good background material for all providers. What else is there? We have recordings of a whole variety of provider webinars that we've done with all the slide decks from those as well. And links to our administrative rules are on that page, as well as some other sort of federal guidance for EPSDT. I think that's the bulk of it, but we want to point you all to the FAQ and definitely the member fact sheet first, and flag that there are more member and family materials coming. And we also have in our sites, it's going to be a few months, but we are working to put together a partner toolkit around communication about EPSDT. As Jessica mentioned, and we try not to have this be a cop-out, but it really has been the two of us for the last year and a half. And we are very excited to be recruiting for additional team members currently. So we're just about to go into interviews for a communication specialist specifically for EPSDT, which is going to be huge. So just know that there are a lot more resources coming, and you can definitely always reach out to us. Our email is in the chat. It's epsdt.info@OHA DHS. It might be ODHS OHA. I can't do it if I'm not looking at it. Oh, it's on this next slide. There we go. So always definitely feel free to reach out to us if you have questions or requests for additional materials, anything like that, or if you're running into any problems or have questions about what's going on with denials or approvals of services. field all those different kinds of things. Any other questions at this stage?
Are there separate provider education documents than what is provided here? And if so, could those be shared with CCOs? I presume they have.
Yes, all of our, yes. So on our website, I think as I mentioned, so there is a provider guide specifically. There's also a memo that went out to all enrolled OHP providers back right before January 1st, 2023 to say, hey, this is the change, pay attention. And then we've done a series of provider focused webinars as well over the last year. All of those opportunities and resources have been shared out to the CCOs. You know, we have in the CCO guidance and in our conversations with CCOs also been clear about like the need to, of course, communicate all this information out to their provider networks as well. And we are, you know, we continue to work on provider education from OHA, but short of knocking on every clinic door, we know we've got a ways to go getting this information out. Other questions?
Yeah, I'm curious if anyone out there has examples of situations where, gosh, it really felt like this should have been covered, or, you know, maybe you have an example of where there was a kind of a denial and then in the end you got it approved. Would love to hear some examples. I'm sure that would be helpful for others. Anybody feeling brave to share today?
Whilst people are bringing up the courage, can I just repeat one of the messages that I heard, which was the importance now of written denials, and that, you know, we are expecting to see those, you know, the history of just that chair side, oh no, we don't cover that, is absolutely now not what's supposed to be happening. And it is so inbred into the culture, and we would really encourage you to be leading the way with the work that you're doing to make sure that, I'm sorry, there is more paperwork, but that's really important for us, because it's also providing then tracking of when we have shortages or where the gaps are, or the way things may need some more support from this system. And it's just, I can't stress enough that for the kids system, this is just really important for us to start to see that happening, and for us to get a better grasp on some of the numbers and what's going on. So, you know, if someone's wanting a higher level of care, again, they should be getting that written denial, or a service that seems a little offbeat and someone says, oh no, we don't do that. Again, it needs to be written.
Thanks for reiterating that, Hillary. And yeah, we've had a lot of conversations about if folks are getting turned away because the provider just say, I'm not even going to refer for that, I'm not even going to try it because I think it'll get denied, then we don't even know who's not getting in the door. And so having a paper trail really helps us advocate and change the system. That also reminded me that we should also share, we are on the verge of hiring a research analyst specific to EPSDT, which will give us some badly needed capacity to actually start taking an across the board look at what is happening with denials and access to services under EPSDT, so that we can, we have not to date been able to, or had the capacity to set up a really like a robust program monitoring. And so we are very excited about that. Thank you, legislature. Thank you, all the administrative powers that be for getting us some staff. So mostly to stay tuned on that, but that is something that has been a really high for us, and we're on the verge of getting.
That's great to ask, or to know, Liz. I was just going to ask you what,
yes,
if you had ever got quality improvement assurance plan together. So it sounds like that's coming.
Yeah, not yet. We sort of have the inventory of all the things we want to look at, but we have not had the actual staff capacity to go there. So we've been dealing with compliance and QA issues ad hoc as things come to our attention. But yeah, in terms of setting up that program monitoring, that's what we're doing. Our the research analyst for posting is currently live. It closes on the 23rd. I will try and find a link and drop it in this chat, or I can send it afterwards if anyone is interested, come to for us. So,
you know, putting on my old utilization management hat, which I did for a number of years, I would think that probably the biggest, one of the things that people should also take away that's really important is that it does need to be, there needs to be documentation that somebody has to respond to. So, and I know from when I used to do utilization management that sometimes was the biggest challenge, is not having the documentation that supports the need for the service. So that's also a really important takeaway for people to have, that if you're wanting a service for a youth, then you need to have something that really supports that service. And also remembering that it all has to follow Oregon administrative rules still. So, you know, there does need to be an assessment and, you know, something, well, typically it's been an assessment and a treatment plan, and the treatment plan then prescribes the needs. At least that's true for mental health services. So, if you're wanting, and I agree with you, Hillary, there needs to be a process of review for the purpose of a denial, because individuals need to have their rights in order to be able to appeal these decisions. That's really, really important. And the best way you can protect yourself against that is by ensuring that you take a look at the documentation that's being sent in with the request, to ensure that it's all there.
And my final point would be, you've now met these humans who are running EPSDT, and they are human and they are willing to take questions and interested and flexible. And so please ask them questions. You know, I know they'll say that themselves, but you know, they really have been responsive when we've asked them questions. So please use that, because I think it's really important as we all, you know, muddle our way through some of these new things, to just know this isn't a compliance issue. They're not going after you. They just want to help and learn themselves in many respects as to where the edges of some of this are. So please, you know, use them to help you get this sorted out.
Thanks, Hillary. It's absolutely true, because honestly, if we don't get those questions, we don't know what's working or what's not at the ground level. And or if we think something makes sense to us, it may be implemented very differently in actuality. So that's how we build a better program and better services for Oregonians. So please do ask, don't hesitate. We've learned a lot from so many, and there's so many more out there that we need to get this information to, and hear about and hear what's going on. So yeah, don't hesitate to ask. We're happy to take questions anytime.
Yes, Jessica is constantly going down policy rabbit trails. I think that we get some questions where we're like, you know, the answer, and some where we're like, huh, we're gonna go figure that one out. So this is definitely, you know, we flipped the switch on this program, which is we're really excited about, and now we're working all the kinks out and trying to figure that out. So, and I think a really good point was made too, that, you know, all of the EPSDT requirements do interact with administrative rules across the board. The EPSDT requirements for how determinations are made sort of take precedence, but we interact with oral health coverage rules, and there's coverage rules about all kinds of different things. And so we're in a lot of space of kind of figuring out how that all works, where we need to make some changes, and or, you know, provide additional guidance to make those things. Any other questions? All right, well, we will send the slide deck, or wait, Christy already has the slide. Maybe you already have it. You
I
will receive
do.
the slide deck.
I will send the slide deck. I will send a recording. I also just want to invite those of you who might be tuning in for the first time. Like, these are held at the same time, second Tuesday of every month from 3 to 4:30. I will drop a link to the website that has the Zoom information. I'm also happy to add you to the calendar appointment if you just want to have these and tune in when it seems of interest to you. Happy to do that. Just drop your email in the chat. And here is the link about these learning collaboratives, as well as some of the other technical assistance that we have available. Next month in March, we're going to be joined by partners from the University of Connecticut Innovations Institute, who have been providing some technical assistance among state and local systems of care. They're going to share out findings from this system reform support instrument tool assessment that they've been conducting with a lot of the local systems. So hope you can join us next month to learn a little bit more about what they heard, what they found, and the recommendations. And yeah, just thank you everybody for tuning in. I hope you learned something today. I sure did. We'll see you next month. Thank you, Liz. Thank you, Jessica.
Thanks for having us.
Appreciate you. Thank you. Thanks, everybody.
Thank you.
Thanks, Christy. I'll leave you to it.